Care of ventilated neonates. First, we have to know what are the common modes of ventilation used in neonates. Number 1 is AC mode or assist control mode. In this mode, the ventilator supports every breath whether it's initiated by the patient or the ventilator. It is often used to allow the patient to rest because the ventilator does all the work. Inspiratory time should be at least 0.3 to 0.35 seconds. Next is SIMB or Synchronized Intermittent Mandatory Ventilation. Synchronize with the baby's breath. If the baby is breathing faster than 60 breaths per minute, only 60 ventilator breaths are delivered and any additional breaths are not assisted. PSV or Pressure Support Ventilation. Patient controls breathing pattern. Inspiratory time is limited according to baby's own lung inflation. It is safer than ACMB. It is used for weaning. VG or volume guarantee. The ventilator will try to deliver the prescribed volume with the lowest possible pressure. The goal of VG is to reduce volutrauma and barotrauma to the baby's lungs. Tidal volume is set for 6 ml per kg. Indications and disadvantages of high frequency. Indicates as a rescue therapy. It is used if conventional ventilation fails. It reduces barotrauma in an increased conventional setting. It creates a small tidal volume. Disadvantages associated with an increase in intraventricular hemorrhage, impaired cardiac output due to high airway pressure. Ventilator settings. Basic ventilator setup, which is usually done by the RT. Prepares and assembles all ventilator components. Perform ventilator and circuit check before connecting to the patient. Set humidifier temperature and fills with water accordingly. In setting up ventilator mode, you have to press the vent mode button on the right and select on the screen which specific mode is ordered. In high frequency, it is important, aside from setting the parameters, to assess the chest wall symmetry and vibration, and also to maintain the piston at the center. To begin with, you have to verify the physician order and to identify the patient correctly. Performs correct sequence of hand hygiene. Wears appropriate PPE. Check alarms on the ventilator and bedside monitor are within normal limits and monitor pre- and post-ductal saturation for patient with PPHN. Resuscitation bag and mask should be ready and connected to oxygen source. To consider dope, which reminds us of the causes that needs to be eliminated when caring for a ventilated neonates. We have to verify the placement of ETD by noting measurement of the lip level. In calculating the lip level, we should know the baby's weight in kilogram plus 6. Example, the baby is 2 kg. 2 kg plus 6 equals 8 centimeter lip level. Ensure that the plastered site is free of redness or excoriation. Utilize Neobar or Leukoplast to secure the endotracheal tube. We have to verify that the suction is set to 80 to 100 mm mercury for term, 60 to 80 mm mercury per preterm less than 1,000 grams. Note that an inline suction system must be used for patient on high frequency. Auscultates breath sounds and interprets the findings. Sedation should be given for patient on high frequency and assist control mode to relax the baby and avoid fighting against the ventilator. Ventilator weaning and extubation. Gradually decrease supplemental oxygen according to patient condition. Stable for at least 24 hours with no inotropic support. Oxygenation and ventilation wise with stable blood gas and X-ray. Noted with spontaneous breathing. Feeding must be withheld at least 4 hours before extubation to avoid aspiration. Always keep pre-intubation equipment ready after extubation. And lastly is to have an accurate documentation in VAP bundle checklist, nurse's notes, and flow sheet.